on the board of Shared Services Connect in the UK. So, like everyone in COVID, we come from broad backgrounds, and so I guess being in charge of managed quarantine services is the combination of a varied career in the public sector in the UK. And so, again, our brief to each of our speakers was quite broad. We're really keen on the insights, the lessons, the things that can be shared from far away. So I'll pass over to Mike. Hopefully you can see us, Mike. We can see you well and truly. We've got you in stereo.
Yeah, I can hear you some of the time and can't hear you other bits of the time. Can you hear me now?
Loud and clear.
You can hear me, right? I'll get going. I was watching you all drinking coffee, thinking I could just do with a cup of coffee, given that it's midnight here in London. So anyway, it's an absolute pleasure to be able to join you today. So you know, what I just really wanted to say first of all is thank you. It's great to be here to share how governments have risen to the challenges of the fight against COVID-19 and the pandemic. So I think it's probably true that we've all learned much, we've all achieved much, and we still have a huge amount still to do. We can all point to outstanding achievements such as our testing and our quarantine policies, and of course our vaccination programs. But I would argue that we can't be complacent. We have to protect the progress that we've made. So the Department of Health and Social Care's overarching aim here in the UK is to safeguard our nation's public health, and in particular to safeguard our vaccine programme as we seek a safe and sustainable return to more normal life and a return to international travel. So our response throughout the pandemic has always been informed by the best possible public health advice. So this is really at the heart of all of the decision making that we make. So in terms of the managed quarantine service, we initially introduced rules in June 2020, which required people arriving in England from outside of our common travel area, so that's Ireland, the Channel Islands, and the Isle of Man, to A, self-isolate, and then B, really provide their personal details and travel information before they travelled. You know, a 14-day travel period for the purposes of both self-isolation and also for providing information was later shortened to a period of 10 days. And then on the 8th of January 2021, we introduced a requirement for all international arrivals to evidence a negative pre-departure test within 72 hours prior to their travel to the United Kingdom. And then, you know, the big shift that we made, and I'm really still very grateful to colleagues in both New Zealand and Australia for the help and support that they gave us. But then on the 15th of February of this year, in response to, and I would argue, the rising threat from variants of concern, we introduced our managed quarantine service. So from that date, arrivals who travelled from or passed through countries on a published red list within the previous 10 days are required to quarantine in managed hotels, as is the case in many other countries now. So these arrivals are only permitted to enter England via a very small number of designated ports and are required to book a managed quarantine package in advance of travel, which includes transport, hotel accommodation, and a mandatory testing programme. People arriving in the United Kingdom from a red list country can also do so only if they're a British or an Irish citizen, or they have the right of residence in the United Kingdom. So since the managed quarantine service was launched in February, 450,000 people have quarantined at home, and almost 30,000 have now quarantined in one of our managed quarantine hotels. We've signed contracts with around 40 hotels, and we're expanding that at the moment to provide accommodation for people to quarantine, along with contracts for approximately 2,000 private sector security personnel. So those arriving in the United Kingdom from red list countries are met at passport control. They're then guided to a dedicated hotel transport area from where they're taken to their hotel. So in the last week, 21,000 individuals are reported to be quarantining at home, and we currently have about 5,000 people who have arrived and have moved into quarantining in the managed quarantine hotels itself. And today we have just over 12,000 people currently staying in quarantine services. So each hotel provides full board, laundry, basic toiletries, cleaning as part of a package. The hotel concierge can arrange delivery or collection of prescriptions and other goods as necessary. Amazon is very popular, you won't be surprised to hear. So around the clock medical advice is also available, including access to GPs, and in some special circumstances, individuals may be able to leave their room for very brief periods of exercises or for emergencies. So the managed quarantine service is very much that, a managed quarantine. And all of the guidance that we've set out, and we have stolen with pride from guidance from many others, is set out on our gov.uk websites, which signpost people to all of the sources of support, tips on looking after themselves, well-being, mental health, all of those key issues that we, and I'm sure you, have also experienced in terms of running these sorts of systems. Now, we of course do understand and we do recognise that quarantine is difficult for people. It's frustrating, people can experience loneliness. But I would argue, and our ministers would certainly argue, that this has to be done as part of rising to the challenges that we face in these unprecedented times, and in particular the variants that we're seeing. And you will have seen recently we expanded our red list to include India, and we're expanding further because of variants we're seeing, particularly in India, Pakistan, and in that part of the world. So as well as mandatory quarantine, we've introduced mandatory testing. So all international arrivals are required to undertake tests in country at their own cost, again pre-booked before they travel. So for most arrivals, this means a test on day 2 and on day 8 of the quarantine period. Testing on day 2 is in particular testing for variant surveillance to inform travel risk assessments and to identify if an international arrival has a variant of concern. Testing on day 8 will identify internationals arrivals who've developed COVID later on in their isolation period. And particularly for hotel quarantine, an individual has to have a negative day 8 test before they can leave the quarantine period after 10 nights. So we monitor, and I'm sure all of you do as well, but we monitor key data, including incoming traveller positivity rates and variants of concern, and we use these to inform our risk assessment processes. So between the 26th of March and the 22nd of April, 501 people arriving from Portugal were tested, of which 3 returned positive results, which equates to 0.6% of traveller positivity. In the same period, 1,787 people arrived from Turkey and were tested, returning 48 positives, or 2.7%. Traveller positivity, and we've got this data for every country and every arrival that we see coming into UK ports. So all positive samples are sent for whole genome sequencing to identify, monitor and limit the number of variants in the UK population. And I think it's fair to say that some of the monitoring that we're doing, we're sharing more widely with other countries, because I think that we have some of the data which is helping others to understand the variants that exist within their own populations. So I think this testing regime provides another level of assurance and really helps to prevent the potential spread of cases into the UK. It allows us to use our genomic sequencing expertise to better track new cases which might otherwise be brought into the country, and to detect new variants as they may exist. And this is helping both in terms of our international and borders work, but also some of our in-country activities. So in terms of some of the challenges and the lessons learned, each of the measures we've introduced of course, adds another level of protection for the nation against the transmission of COVID-19. So in particular, the risk of a new and in particular a dangerous strain being imported. Now, in order to stand up the new managed quarantine system quickly, we've had to rapidly stand up several interconnected, complex systems in parallel. I'd suggest that these systems were never really designed to work in tandem. For example, our immigration system didn't link with our quarantine hotel booking system. Our data for arrivals didn't link with our test and trace capabilities. So one of the things we've had to do, and I know that the word agile is almost certainly overused, but we've had to be agile in really implementing a system that operates as well as it can and protects the UK as far as it can. So there have been some real challenges with implementing a system that has to be dynamic and respond to additions and removals from the red list of countries in particular. So currently we have 40 red list countries and we've kept those under close review. And from 4 o'clock this morning, so in only a few hours time, we will be adding Turkey, Nepal and the Maldives to our red list countries, and we will not be allowing direct flights from those countries, and anyone who's been in those countries in the last 10 days will have to go into managed quarantine as well. So in terms of the hotels and moving to that, some 50 to 80 security staff need to be recruited, trained and deployed for each new hotel that we open, and we're buying up more and more space in hotels. And one of the challenges for us is just how sustainable is that model as we go forward, and how can we keep doing that often with as little as 3 to 4 days notice. And what we're finding more and more as hoteliers are looking to the future, it is becoming harder and harder for us to get the hotel accommodation that we might want, and certainly for a period of time. Now, I think ensuring a robust system from departure through to hotels has required a significant amount of collaboration across a diverse range of government and non-government stakeholders. Now, each of those has their own interests in facilitating the restart of international travel routes, and many of those stakeholders have the power to affect demand and capacity. So keeping everyone on side has been one of the real challenges that we've faced. We've put in place, I would argue, a proportionate system in extremely limited circumstances where it's not possible to accommodate visits. For example, for people who are severely ill or dying or need to visit a dying relative or member of a household, we have allowed some exemptions to exist, but those exemptions we've tried to keep as limited as possible. But in order for people to get those, they do have to supply evidence from the hospice or medical facility that they're visiting. I think we've got the system just about right in this case. So each application is assessed sensitively and in line with our guidance, but still within our overarching aim, which is to protect the nation from new variants. Our baseline has to be that if an individual voluntarily chooses to travel in these unprecedented times, they must factor in the requirement to undertake the mandatory and legally binding 10 days of quarantine when entering the United Kingdom. So this is how we protect our families, our children, our healthcare system, our economy, and I think importantly, as I was saying before, the progress that we've made over the past weeks and months. You may have seen in the media, we've now introduced a traffic light system. So the UK government published the conclusions from the Global Travel Task Force in April this year in order to look at ways of supporting the safe reopening of international travel. Reducing the risk of variants clearly remains our top priority. So we have adopted a risk-based approach to reopening international travel. So as announced last week, we're launching a new approach for England, and we're working with the other parts of the United Kingdom. So we're introducing variable restrictions to differentiate countries depending on their COVID risk factors. which will form the basis of our red, amber and green traffic light system. Given that the virus is still spreading in many parts of the world, people should not be travelling to amber and red list countries for leisure. That's been a very clear message from the government. 10-day managed hotel quarantine requirements will remain in place for those permitted to return to England from red list countries. Quarantine at home alongside proof of pre-departure test and day 8 testing will be required for those returning from amber listed countries, and those arriving from green list countries, the lowest risk countries, will need to take a pre-departure test up to 72 hours before their departure back to England, and a single PCR test on or before day 2 of arrival in the country. So in summary, public health and safety is at the heart of everything that we're doing in our fight against COVID-19. I think we've come far, but we cannot be complacent. The point at which you become complacent is when you go backwards. We have to protect the progress that we have made. So we believe in the UK that the combination of strong border measures, managed quarantine, testing and enforcement are the best way to effectively reduce the risk of importing variants whilst reopening international travel in a safe and managed way. So thank you, and I know other colleagues are going to speak, and I'm very happy to answer questions later.
Thank you, Mike. Thank you. We'll save our questions for the end. Sorry, Mike, I've just got a bit of an echo here. I'm pleased to now introduce Dr. Lynn James, who's the Director of International Cooperation in Singapore's Ministry of Health. So Lynn has completed her medical training and postgraduate specialty training in public health at the National University of Singapore, and like all of us, has found her way to the world of COVID through various roles in the public system, and in her case, the public health system. She has been the Director of Epidemiology and Disease Control for 8 years in Singapore, looking at surveillance, prevention and control of non-communicable diseases, health services research, public health intelligence of public health events and international collaboration, which all sets you up in good stead for COVID-19, Lynn. So I'm really pleased to welcome Lynn. It's very early for Lynn, so you possibly also need coffee. But I'll hand to you to give your perspective and insights. Thank you.
Thank you very much. Want to wish everyone a very good morning, and to Mike a good night soon. And you know, it's a pleasure. It's a pleasure for Singapore to be able to share at this, you know, very interesting platform. We've been having regular exchanges with Australia and New Zealand, so this is really, you know, great to be, you know, connected with colleagues again. This is my first time using Microsoft Teams, so I'm going to see whether I can share my presentation slides. Is this being, can everyone see this?
Yes, we can.
All right, great. I'm so happy that it worked. Okay, so in my presentation, I'll be giving an, let me see, okay, oops. Okay, is it on to the next slide now? Because I can't, yeah, okay. My presentation will cover briefly the COVID-19 strategy in Singapore and our, you know, how we have actually opened our borders, and also more information about what we call stay home notice, which is the same as, you know, the quarantine that's imposed on incoming travelers, and also how we actually do quarantine for close contacts in Singapore, and some issues of concern that we are facing. Okay, so in terms of our COVID-19 strategy in Singapore, I think a lot of it is guided by our experience from SARS. We were really very badly hit in 2003. So since then on, since at that time until now, we have been constantly actually increasing our preparedness and putting in measures, you know, and building up our capability and capacity. So we The whole COVID strategy in Singapore is governed by our ministerial task force, which is a multi-agency task force headed by the ministers of almost all government agencies and ministries. And was set up actually the day before we had our first imported case. And our strategy is really focused on containment. So from day one until now, our focus is containment. That means we want to try and identify every possible case, leave no stone unturned, identify every possible case, isolate that case, ring fence all close contacts around to minimize the spread of the virus into Singapore. And we have actually used a slew of tools to actually guide us or underpin our containment strategy. The very important thing that really underpins all is our testing. And for us, we use PCR as a gold standard for testing. And we have, since the start of the outbreak pandemic, continuously built up our national capacity and capabilities, both in the public and private, to provide this testing. So right now, we are doing a daily average of about 30,000 tests a day, with a positivity rate of about less than 0.1%. So you can see that we are actually testing very widely. And our capacity can go up to about 50,000 tests a day. Now, beyond our PCR, we have continuously expanded our toolkit for different contexts and different use cases. And we are also introduced antigen rapid testing into our toolkit, but we only use this for very low risk settings. For instance, if we have a mass event and organizers want to increase the capacity of the participants attending, then beyond a certain limit, they have to actually do antigen rapid testing to ensure that these participants are actually not carrying the virus. And these are point of care tests that can yield results in about 30 minutes and have a fairly high accuracy and specificity and sensitivity. We also actually impose, besides doing surveillance on people who fit our suspect case definition, and those who present, in fact, anyone who presents at the primary care setting with acute respiratory infection, we advise the population to, as soon as they have even a runny nose or a cough, to see their GP immediately, and they will actually be tested for COVID. So that is one ring of our surveillance testing. And also we do regular screening of high risk groups. And these are frontline workers, those working in the border operations, are migrant workers because we live in congregate settings, and also our maritime workers who are engaged in work where safe measurement measures are difficult to comply with. So for those at risk in those kind of settings, we do regular testing, either every 7 days or every 14 days. The other tools that we use are contact tracing and epidemiological investigation, because as mentioned, we want to track and find the source of infection for every single case that is identified in Singapore. So we do very rigorous contact tracing around every case, and we ring fence the cases, the close contacts. And we use genomic sequencing to actually help us link up all cases, and that's how we have actually established links between clusters, and even identifying the source of the clusters by doing genomic sequencing. And to aid our contact tracing, we leverage technology, and we have a slew of technological tools that are used. One is what we call a trace together, which is on either you can use your mobile phone application on your mobile phone, or a token for those who don't have a mobile phone. And this actually sends out Bluetooth signals to other users around you. So, and that is determined by the distance as well as the duration of contact. So because when you ask someone who are your contacts, some of them they might know, some would be unknown contacts. So through this application, we are able then to track the contacts which the confirmed case themselves might not have identified. And this information is There's no geolocation on this, it's just proximity of contacts who are close to you. And all this data actually resides in your phone or in your token. So it's, there is no issue of, confidentiality of data in the sense of a breach of confidentiality, because it resides in the person's phone on his app, and only when he's a confirmed case is passcode given to you to release that data to the government contact tracing center. We also have another digital tool called the Safe Entry, which is a digital check-in and check-out. So every established business in Singapore has a QR code, and so they just have to scan using the application, and this will tell you how long you have been in any vicinity or any establishment. So this has helped us reduce our contact tracing from the usual 4 days when we first started, early in February, till about less than 2 days now. Another, kind of measures that we also take or initiatives is really vaccination that we have started. We have progressively vaccination our population for herd immunity. We have now vaccinated about almost 20% of our population received 2 doses. We started in late December and we went by high-risk groups. So it's those who are healthcare workers, those who are the frontline essential workers at higher risk. They were vaccinated initially and they were given priority, and now subsequently we are releasing different age bands. So at the moment now, those 45 years and above are given priority to receive their vaccination. We are also, using, as Mike has said, research and information about this is continuous, and we're getting new information and learning more and more about this virus, and so we keep adjusting our policies in line with the science and the evidence. So all our policies are actually based on evidence. Well, at least the evidence that we know at that point in time. Now to touch in about our border reopening strategies. So we had our lockdown maybe about March and May last year, and we lifted it in early June on the 2nd of June. And since then, we've had to actually open our borders. So because in Singapore, we are very small, we are a global city, we depend on global trade for our survival. And so we don't have the luxury of keeping our borders closed for too long, and we've had to reopen our borders, but we do so in a very calibrated, risk-based approach. And what do we mean by this? We assess the risk of importation of travelers, and then we mitigate the risk with appropriate public health measures. So we do continuous public health assessment of countries all around the world. And we do a qualitative as well as a quantitative assessment. Quantitative in terms of what are the case count or the incidence rates in those countries. Qualitative also looking into how these countries actually manage the outbreak within their borders. What is their testing strategy? Are they having a very wide testing strategy? What is their response to be able to manage cases that are identified? And what are the resources? So all that leaves us to make an informed decision about the risk categorization of that country. So our premise is that if somebody is coming from a high-risk country, the risk of them being infected is higher. If someone is coming from a low-risk country, the risk of them being infected with COVID is actually lower. So that's our risk-calibrated approach. And then when they come in, we actually mitigate the risk with appropriate public health measures. So we have identified, or rather, categorized countries into low-risk and high-risk countries. Low-risk countries, all they need to do is come in. They have a PCR test on arrival. They are subjected to 7 days of what we call a stay-home notice. So it's equivalent to what you call a quarantine. We call it a stay-home notice. From these low-risk countries, they can do it in their own homes. If you're coming from high-risk countries, you need to serve your stay-home notice at dedicated facilities. Initially, it was 14 days. We have just, since the early May, extended it to 21 days. I have to caveat that this is not based on science at the moment now, but on abundance of precaution because of the emerging variant that was coming out of South Asia. And so we'll be monitoring this and see whether we need to calibrate it down back to 14 days. We also do PCR test. Initially was at the end of this quarantine period at 14 days. So now that it's extended to 21, we do it at 14 days as well as 21 days. And this is to pick up even the asymptomatic cases as well. We have a small group of countries where we have what we call unilaterally opened these countries to, and Australia and New Zealand fall into this group, where travelers from Australia and New Zealand, if you have been in that country for now it's 21 days, you just need to do an arrival PCR test. You self-isolate until the negative test, and once you get the negative test, you can move around freely, just as any other resident in the country, as long as you observe the safe management measures, which is mandatory mask wearing, social distance, safe distancing, and and this is for all types of travel, leisure travel included. The other one that I talked about for stay-home notice is really only for certain categories of travel, and that is inclusive of returning residents, as well as those coming into Singapore with a legitimate reason, and mainly it's for work or business. We have also had another, another travel, what we call green lanes, and these are negotiated lanes for business and official travels, which we do bilateral negotiations with countries, where they do a pre-departure test, and on arrival, a PCR test, and they are self-isolated until a negative test, and then on they do what we call a controlled itinerary, very limited activities, and they have to keep no mixing with the community and with the larger population, and they have to keep very strict measures, their safe distancing measures as well. So now I'll share a little bit more about what we call our stay-home notice. So as mentioned, this is our isolation and monitoring, and we either do it at the place of residence or at dedicated facilities. Place of residence is just for those who come from very low-risk countries. They serve 7 days, and majority of those coming, other travelers are serving their stay-home notice in dedicated facilities, which are actually government chalets or resorts, and we're using now lots of hotels as well. And for hotels, and where monitoring is much easier, because the management of the hotel can actually monitor the travelers. We keep them in their rooms, because once they enter their rooms, they cannot leave their rooms. If they open the door and leave, the door will self-lock, because they don't have an entry card access to get back into their rooms. So that's how we ensure that they remain in their rooms. And then we picked up a few people who leave their rooms by leaving their door open, but the doors will self-close. And so that's how we monitor that compliance in the dedicated facilities. And for those serving stay-home notice at home, we actually leverage on technology. And so every person who's serving a stay-home notice at home is given a kit. And this kit comprises a wearable wrist device, what we call a gateway, where they need to plug into a power source, as well as a user guide. So once they reach home, they need to plug this gateway into the user guide, and it will then have signals with their wristband. And if they move more than 30 meters away from the gateway, alert signal will be sent to the monitoring agency. So this is how we ensure compliance for those who who are serving the stay-home notice at their residence. And it's a tamper-proof, waterproof device. And if there's any, if they're out of range, signals will be sent, and then compliance checks will be done on the person who's serving his stay-home notice. And this has allowed us to actually scale. and also, make sure that, we are able then, because to cater to a large number of travelers. I'm just going to touch a little bit about our confirmed cases. So as mentioned, we try and identify every single case in Singapore. For those who are confirmed, every case is isolated, either in hospitals for the initial phase of their illness, or if they're ill, and if they're very severe, or if they are asymptomatic and recovering, they're sent to what we call community care facilities, and they are kept isolated for 14 to 21 days. We also do quarantine for close contacts. We identify close contacts of every confirmed case, and they're issued with quarantine orders. And this is, of course, legally enforced. And they are isolated either at home using similar monitoring devices as those on stay-home notice, or in government quarantine facilities. They undergo a swab at the entry and exit of their quarantine period. And also we offer financial assistance to either the businesses or to the person being quarantined by giving an allowance for the days that they are quarantined. And we also tagged, for compliance if they break quarantine. And we also, for a larger ring of close contacts, close contacts are what we identify as close contacts are quarantined. We also draw a wider circle around contacts, and we do what we call phone surveillance. Calls are made to them every day. They're allowed to carry out their own activities, daily activities, but we make phone calls to them every day to ask them how they are doing. And at the end of this 14-day period from the last contact they've had with a confirmed case, they are subjected to a PCR test as well. So this is just a diagram to give you a model of all the different agencies that are involved in our stay-home notice for when a traveller comes in. So before arrival in Singapore, he has to submit to our Immigration and Customs Authority what we call a Singapore arrival card within 72 hours of his arrival, which answers questions on his past history, where he has been for the past 21 days. So this is how we know which countries we have been and which then category we place the traveller in. And also with our Civil Aviation Authority of Singapore, which then ensures that all airlines do pre-flight checks before they even board the plane into Singapore. So there's some countries, from high-risk countries, they're required to do a pre-departure test. They also route to check whether this patient or this traveller has had contact with a past case, a confirmed case, or his risk activities, whether he's unwell. So they're all supposed to do all those pre-checks before the traveller boards. So this is how we also then reduce the risk of importation into Singapore. And even before the traveller can board the flight, he needs to actually get an approval to be allowed to enter Singapore. So he needs to get the approval from the relevant agencies. If he's coming in for work, then it will be from our Manpower Ministry. If he's coming for, for some other pass, then it's from our ICA authorities, or even, whichever relevant agency is overseeing his entry. Once he arrives in Singapore, our Immigration and Customs Authority is the first point of contact. It checks all the travel documents and checks that he has a pre-departure test, and then issues him with a stay-home notice, which is legally binding. And he either goes home to serve his stay-home notice or goes to dedicated facilities. But before he can be sent off home or to the dedicated SHN facility, he has to do an on-arrival PCR test. This is done by our Civil Aviation Authority and our Changi Airport Group at the airports, and by our respective other agencies at our land or our sea checkpoints. And our Ministry of Transport then oversees transport to these dedicated facilities. During SHN, there's all the enforcement and compliance to ensure they don't leave their premises. And if anyone is detected or has any symptoms or needs to go, MOH will then, Ministry of Health will then oversee the conveyance or management of these cases. There is also ability for everyone who is serving their stay home notice to see a doctor if he needs to. So, you know, he can actually make a call to the hotel front desk, and then transport will be arranged, appointments will be booked for them to actually see a primary care physician. And then when they leave this quarantine, there will be either on-site PCR test done for them if they're in a managed SHN facility, or if they're serving at home, they need to go to one of our regional testing centers to have their PCR test. And this is overseen by our health promotion board, which has set up many regional screening centers all over the island to make screening accessible to everyone. And the relevant agencies who are then overseeing the stay of this SHN period will then give the green order to then release this traveller from quarantine, from stay home notice, and then he's allowed then to join the community. And
thank you. I'm just conscious of time, and I really appreciate hearing a slightly different take on quarantine, but really interesting to us. And there was a bit of chuckling about the room doors being locked that you might not have heard here. And I'm sure we can pick up some of your final reflections during the Q&A session, but I do need to hand to our Australian contingent, so thank you. So I'm pleased to also welcome Kim Lawler and Nerida from New South Wales. They're both part of the New South Wales State Health Emergency Operations Centre, SHIOP. And on International Nurses Day, just recognising that we have two nurses with us from New South Wales Health. And just to give a perspective on the experience of New South Wales and some of the insights and lessons that we can share. I think we do have quite a bit in common with you guys. So I'll hand over to you for your presentation. Thanks.
I've only got a few slides, but it might be easier to talk to, so we'll just, if we can, try and share our slides. If not, we'll just talk anyway.
So this is our take of New South Wales managed isolation and quarantine. Just to let you know, this is specific to New South Wales only. So all the other states and territories, while they do have quarantine in place, it will obviously vary to what New South Wales does. So we're quite independent when it comes to state and territory driven. However, we do collaborate with our colleagues in other states and territories. So the New South Wales hotel quarantine program came into place in March 2020, and that was based on the public health order that was developed in response to the ongoing public risk of COVID-19 and the risk of introduction into the New South Wales community from returned overseas travellers and also the flight crew. The public health order is signed off by the Minister of Health under consultation with the Chief Health Officer. So that came into place as an air one, and there's a maritime one as well. The directives for that is that every overseas traveller and flight crew has a minimum 14-day quarantine period. This is either in a police managed hotel, which Nerida will go through in more detail, and also or otherwise as a special health accommodation, which is one of our medical facilities run by one of our local health districts. It's basically applicable to anyone who enters New South Wales via overseas destinations from everywhere except for New Zealand. And there's the New South Wales testing program in place for quarantined transport workers. In relation to the flight crew, they are ordered to undertake mandatory quarantine for either the 14 full days or until their next flight out into another country. And then with the maritime public health order, that was also put in place because of the risk of potentially bringing COVID off the vessels. So they're only authorised to disembark by the commissioners of the police to undertake any sort of essential task, or if they're required to seek medical attention. And then every vessel must have a COVID safety plan in place. Prior to entering into hotel quarantine, we do have a robust exemption process, which has been in place since probably just after the program started. And basically any individual can apply for an exemption, noting that most exemptions, if for high risk, if people are requesting to do self-isolation, it generally is never supported. Except in the absence of flight crew who reside in New South Wales and they have a COVID safe plan, they can actually self-isolate at home, but there's strict plans in place for that. Basically, the exemptions team, we've got quite a large exemptions team. I think there's about 30 FTE and about 10 to 15 staff working 10-hour days, 7 days a week to go through all the applications and decisions. So basically, we receive the application, it gets triaged and allocated to the relevant decision team. There's a number of different teams, such as flight crew, unaccompanied minors, maritime, the general public, and then also straightforward declines. So those applications are reviewed by the case manager with the decisions team. The decision outcome is determined by our authorised medical officers, and they're authorised under by the Chief Health Officer. The decision outcome is provided to the application by the email, and then if there's an appeal, they're requested, then that goes to a panel of medical authorisers. Where we do tend to give exemptions, it's more around time-limited exemptions. So if someone's coming back because they want to attend a funeral, or if they've got, family members who are dying or very sick in hospital, we will often facilitate a sort of time-limited exemption, which might be a period of 2 to 4 hours to support people in grieving times, and then these applications must be completed prior to arriving into Australia. Once people get into Australia, they're then going to hotel quarantine. So I'll hand over to Nerida, who is our subject matter expert in hotels and our lead for the program.
Can I just check before I start? Can you, hopefully you can see the slide. It's just, this is sort of, I guess, a nice slide to sort of demonstrate. And I think Mike and Lynn has also talked about the quarantine program is a really collaborative effort across all agencies. So this is our end-to-end process of quarantine from when somebody arrives, and all the different agencies that are involved in keeping the person in quarantine safe, but also the New South Wales community and the staff working in the quarantine program safe. So from yesterday, we've got 2 models, which I'll talk to on the next slide. But yesterday, what we call is the New South Wales Police managed hotels, but it's a very joint operation between New South Wales Police and Health. We had 175,000, more than 175,000 people go through our quarantine program, the New South Wales Police managed hotels. We have 20 hotels that are used in the quarantine program, police managed hotels, and we've got 3 dedicated health hotels, which I will just explain a little bit more on the next slide. But as you can see there, the agencies that are involved, there's health teams at the airport, there's transport teams, there's ambulance. When you get to the hotel, there's security, health again, ADF, which is the Australian Defence Force, and all the hotel staff that are providing support in those hotels. So as with all quarantine programs, it's such a collaborative effort in making sure that it stays safe for everyone involved. So this slide sort of demonstrates our model as a very brief overview, but basically everybody who enters New South Wales goes into quarantine, and it's 14 days unless they're confirmed COVID positive, and then their stay is extended. But when they arrive in the airport, everyone is screened by a health team, and that's screened for COVID symptoms, but also complex medical issues. I think when we first started the program in March last year, it was quite a different cohort of people that were coming through the program. So they were real expats that, took the warning and returned home. And they were relatively well and had care and medical care overseas. That changed over time, and we were seeing people come back from countries that may not have had great medical care and had returned with quite complex medical and mental health issues. So we had to change our program to reflect that. You know, we were seeing people that had, you know, renal patients, pregnant women who'd had no antenatal care and were 32 weeks, those sort of conditions that we need to make sure that we can provide care for them in our quarantine program. So they're screened at the airport by a health team, and anybody who has COVID symptoms or has been identified as having complex medical care are transferred to what we call the special health accommodation, and that's run by a district in New South Wales, Sydney Local Health District, and it's supported by what is RPA Virtual, which is more than telehealth. It's doctors and nurses, and it's really set up like a hospital. They do telehealth into the hotel rooms, and, you know, do monitoring of saturations and blood pressures. There's nursing staff working on every floor, and it's much more, they're all health staff working within those health hotels. And that's compared to the 20 police managed hotels. So there's health staff in all of those hotels, but how we differentiate the care and treatment that we can provide, it's more like a GP level healthcare in the police managed. Anyone that requires more than that, we transfer across to special health accommodation. And then we've obviously got escalation pathways to the hospitals as well, the emergency department. So all passengers, so if they go to special health accommodation, they're swabbed at the airport. All other passengers in quarantine are swabbed on day 2, and it says they're day 10, but that used to be day 10 and that's been moved to day 12. There's been lots of talk about variants of concern. Any passengers who are positive on day 2, and it's confirmed all positive passengers, their COVID PCRs are genome sequenced. So anyone with a confirmed positive variant of concern, that whole plane, everyone who arrived on the plane with that person, we do a day 7 swab as well. So there's an additional swab within that program. And I guess just to add there, in regards to our swabbing regime, we're currently about to amend the public health order to mandate a day 16 swab after departure from quarantine. And I think that's similar to what I guess Singapore's reflection of extending their quarantine period for those high risk countries. It has been strongly recommended when someone leaves quarantine that they have that day 16. It will now become mandatory. And that we're expecting that amendment to happen in the next day or so. Yeah. So they are transferred between SHA and hospital depending on whether it's complex care or COVID positive. Okay. So I guess where we're focusing within the quarantine program, and I guess what I'll talk a bit about is the future considerations next time, but really where we can't, you know, our program is probably not going to change too much within this year. We're really hoping to get a vaccination rate probably up around the 80% rate before we really change the program too much. And I think we're all talking about risk, similar to what both speakers have spoken to today, and it will be around the sort of a similar sort of traffic light or risk assessment according to the country of origin. But really our focus is really about keeping the passengers safe in the quarantine program and the staff. So we've got quite a focus on quality and safety within the program, and trying to really strengthen that, because we've got as with New Zealand, well, no, we have had one positive case in the community recently, but really in reflection to other countries, no community transmission. So really the risk is all around the quarantine program, and it's around managing that risk for the passengers and the staff in that quarantine program. So that's where we've had a real focus. You know, we have a very strong staff surveillance program. Like Singapore, they have a QR code when they enter. they all complete daily saliva surveillance saliva testing. In the special health accommodation, they also do a weekly PCR on top of the daily saliva. We've got the vaccination program, so all hotel quarantine staff and airport part of that 1A program. So we've got a very strong focus on that quality and safety, infection control in around the programs, trying to strengthen the infection prevention control resources within the hotels. So we work closely with the Clinical Excellence Commission in regards to infection control, and we're putting link nurses in every 1 to 2 hotels. There'll be a specialist infection control nurse in each of those hotels. Each hotel's audited weekly, and there's an enhanced auditing program around that. So that has very much been our focus to date and moving forward in the next 12 months. The vaccination program, so the rollout for quarantine staff and household members has been a really big push. And we're also, I guess, in regards to ventilation and air pressure, that's also where we're focusing as well, like everyone else. And I guess the evidence around that we're still needing to strengthen, I think, and have a greater understanding. So we've got more than 6,500 hotel rooms, which we've currently done air pressure testing on all of those, which is no small feat, and retesting. And we've also done things like, you know, all staff have got all PPE in the hotels. There's a really strong focus on that, but we've just fairly recently, and you may have been doing it for a long time, but all passengers when they open the doors now must wear a mask. It's interesting, you know, hearing Mike talk about short periods of exercise outside. So all our hotels are really in our central business area, and there's no outside activity except for in the special health accommodation. There's a courtyard, and really it is for medical purposes that someone is allowed to go out into the courtyard. So, and that's really been a risk mitigation strategy in relation to, and a choice, and we're really aware of and the impact that quarantine for 14 days can have on people's mental health, and we've tried to strengthen that program around the mental health support and medical support in the program, keeping in mind that we've made that decision that we don't allow that outside exercise. We're really trying to improve our proactive communication as well. We had a national review, and we've got a dedicated quarantine website that's really focuses on the whole person. Previously, our health advice has been very much around, you know, you'll be swabbed on day 2 and day 12, and the very medical approach, but it's, you know, it's supporting people coming back and being prepared for quarantine. If you're having to work or school, or you're bringing kids back, how does a family survive in quarantine for 14 days with 2-year-old? You know, those sort of things is what we're also trying to improve on. So our future considerations is really dependent on our vaccine, how our vaccine rollout is, and I think, as Kim has mentioned, you know, states and territories, as with quarantine, has a different program in relation to vaccines. But what we're really trying to hopefully achieve is where we'll start to feel a bit more comfortable. I've, you know, been quoted around that 80% mark, but currently, we've, you know, you may or may not know, but we've got 8.9 million people in New South Wales, and our total vaccinations to date is 248,000. So UK, we're very envious. You've done an amazing job in your vaccines, and hopefully we'll get there. We've 80,000 people have had their second dose. So we opened our MaxVax centre on Monday, which has the capacity of doing 30,000 vaccinations in a day. So hopefully that will really strengthen our rollout and being able to consider future options for quarantine. But those options, I think it's probably similar to, I guess, what you've both spoken of, but, you know, those low risk countries, you know, I guess currently we've got that green zone with New Zealand, which is fantastic, but those low risk countries that there is still risk having that home isolation from the airport, or potentially a combination of home, for a higher risk countries, combination of home and hotel, so that they go in, we're able to assess them, that they will be safely able to self-isolate at home. We can do their COVID tests on arrival. or day 2, and then prior to departure, and ensure that they've got the things in place at home to be able to self-isolate. I guess we've got quite a few people return that actually don't have a home to go to, and that they will go and stay with relatives and things like that. So I think for a long time we're still going to have that option of quarantine, because there will be people that won't be able to safely self-isolate. We have had multiple discussions around purpose-built facilities, and maybe we have a real need to have seasonal workers for our horticultural and meat processing, and maybe those sort of facilities might be appropriate for groups such as those. So there is really how do we reopen Australia? We can't stay like this forever. But it is dependent on how our vaccine rollout is, and availability of vaccine is also been a struggle, and variants of concern like what has already been mentioned today. And that's it for us. Yep. Unless there's anything.
No, I think that's it. I think the only other thing to note, the special health accommodation has been quite robust, and we've had 0 transmission. From that program. Obviously we have had some transmission in the police managed hotels, but the special health accommodation has had 0, which has been fantastic. And they actually hold all the positive patients too. So that program is very robust.
Fabulous. Thank you very much, Kim and Nerida, for that perspective and for all the accents coming through. We'll just see if people have got any questions for anyone from the panel, or perhaps a question that applies to all 3 of our speakers. Certainly a lot of what you said resonated, and for me that theme of how do we reopen, it's certainly a conversation here, but like for yourselves, it's quite fraught from a risk-based point of view. So are there any questions from the floor for any of our international guests? I've got one quick question for each of you, maybe starting with you, Mike, is if you had to crystal ball what your system of quarantine might look like in 12 months' time, are you able to give us sort of a one-sentence description of a year from now?
When I joined the programme, I thought I was going to join a programme that lasted for about 6 to 8 weeks. When I spoke to Matt Hancock, the Secretary of State, today, he said that he thought quarantine hotels would still be in place in 12 months' time. So I think that our system will be more risk-based. I think there'll be more use of digital. I think there'll be more use of data to help us to manage those risks. But I still think there will be an element of physical quarantining within the system. I think that our test and trace will need to continue to develop as well. And the collaborations that I talked about earlier are going to have to continue to grow so that we can, as travel increases, we can actually manage the border. At the moment, if you take Heathrow Airport, which some of you may know, on a normal summer's day, prior to the pandemic, 400,000 people arrive at Heathrow every day. At the moment, it's 10,000. So as we reopen travel, we're going to have to make sure that our healthcare systems, our border systems are far more integrated and far more sophisticated than they are at the moment.
Thanks, Mike. And Lynn, if you had to crystal ball 12 months into the future, what do you see?
Oh, that's really a difficult question because I don't see things changing for a very long time. And I think we'll still have to kind of rely on quarantine. But I guess it will be how can we use the limited resources that we have in the best way possible. How do we then, refine our risk calibration of visitors, identify which are really truly the higher risk, and put them into tighter accommodation, and maybe then use home quarantine where, for those who have suitable home facilities to then allow them to actually safely and maybe improve. We have to leverage a lot on technology to ensure that we are able to do that tightly. And I guess also underpinning all this is whether we can even come up with a faster PCR test, because there are limitations in terms of even like, discomfort to the person, having his nose swabbed, and also the length it takes to do a PCR test, which is the gold standard that we're using. So we can make all that easier, then I think it would help the whole process. Thank you.
Thank you. And Nerida?
Yeah, I think, unfortunately, I do think we're still going to have a hotel quarantine system in 12 months as well. I think, with risk assessment, I think we also need to bring the community along with us. I imagine it would be similar to New Zealand. We've got no community transmission, and there's a real expectation from the community that remains. And I don't know if we open up with how do we manage that risk, and what's risk is doable and manageable, I guess, and making sure that that's how that's communicated and how we bring the community along with us as well.
Right, thank you. Now, any other questions? Andy, do you have a question?
I'm Andy Milong from Managed Isolation and Quarantine here. Firstly, thank you for your insights. I think many in the room like me will be interested in the sort of graduated risk-based model. And I'm particularly keen to understand from the two jurisdictions that have home managed isolation, what your experience of compliance with that is, particularly Lynn, from a technology-based, technology is great, but we all know, and I've got quite a lot of experience in electronic monitoring from another life, but we know that people find a way around those systems. So it'd be interesting in the observations on compliance levels with those home isolation enforced stays.
Perhaps Lynn, to you first.
Okay, all right. I hope I heard the question clearly. So it's about the compliance with our home monitoring system. So far, we've actually had quite high compliance. Of course, so there are many different layers. One is the technology itself, that we are able to actually, it's been quite accurate to be able to, monitor. And if you leave that outside that range, it does send. So the validation tests for those have been done. And we also actually do quite regular enforcement checks, So even like, let's say the person, he's supposed to take a camera, a visual of where he is, and so when his phone calls are made to him, they will actually assess whether it's you are in the same position and the same place. So they do ensure that, you are still, because there's no geolocation for that tracking system. So to ensure that you're still in the place that you have declared, and we also take enforcement very strictly. So besides the regular checks of phone calls and video and surprise checks, so officers do go to the residents to make sure that you are there. And then it's as you say it is, and also if there are any people who then, found to have left their accommodation either through the technology or some other, reasons they have found out, actually there's very strict enforcement. And so we kind of like make examples of these cases. So then compliance is fairly high.
And Mike, quick perspective on compliance with the home-based models.
Yeah, I was going to say, first of all, compliance in the hotels is extremely high, and I'm sure everyone finds that because we have far more control over it. I think that it would be fair to say compliance with home isolation and quarantine is, what word should I use? Mixed. So it's fair to say that we have a system, as Lynn has just described, of daily calls. We find that lots of people don't answer the daily calls. We do repeat calls. In fact, we phone people every single day. We've introduced a lot more visiting, so we now have up to 10,000 visits done each day by a private security company. And if they can't pursue the compliance, we have involvement of the police forces to do checks and apply even more stringent enforcement actions, but we are still finding that there are levels of non-compliance which we find unacceptable. So, you know, we're looking for other ways of improving compliance with public messaging, all of those different things that are within our toolkit. But I think home compliance is still a challenge for us.
Thank you. I think that's it for our questions from the audience. Look, thank you so much for your insights. I hand you a virtual stuffed kiwi in acknowledgement of the time you've made, including at awkward times of day. Apart from anything else, it really feels like there's a community of people out there who understand each other's challenges, each other's pain, and are grappling with the same questions of the future. So if nothing else, it's a problem shared, but there are certainly some insights there that will be useful for us to take away and think about. So thank you. You're very welcome to stay for a video we're going to play of Dr. David Nabarro, who's the chair of Global Health and co-director of the Institute of Global Health Innovation at Imperial College London. We asked him for his perspective on where we're at in the COVID response, and in particular the role of isolation and quarantine in that response looking forward. So just a few minutes of video from him before we have our pre-lunch reflections, and then we get to wander around and eat. So thank you very much all of you. Can we just acknowledge yesterday? Okay.
No sound.
Nearly there.
White speakers need to be.
It's one of the management division.
Sorry guys, 1 second.
Speakers on.